Hello, my name is Jim McLaughlin, and this is my presentation on raising the bar for child health. So, to give you some background on this case, children from low-income families often face multiple social and legal challenges that negatively impact their health. While pediatricians can treat medical conditions, they often lack the tools to address underlying social determinants of health, such as housing instability, which is unsafe living conditions, food insecurity, which is the lack of access to proper nutrition, and then education barriers, which comes from limited school support for children with chronic illnesses and legal obstacles, which is the difficulty accessing government assistance programs such as food stamps, healthcare, and disability benefits. Um, and on my side, you can see I have factors of how it happened, where it happened, and why it happened. So, going on to the prevalence of the issue, reports show that 62% of low-income patients fail to attend follow-up medical appointments, which highlights the systemic barriers to healthcare access. The ages affected by this program are typically infancy to adolescence, and then in terms of gender, this program does not target specific gender, but it usually targets family as a whole. So, how did the medical legal partnership for children come to be? Well, there's factors influencing the decision process and the making of this program. There's three of them: economic, cultural, and social. I'm going to break down economic first. So there is poverty and financial instability. Families with low income struggle to afford housing, food, and healthcare. There's limited legal aid resources, meaning the legal aid system is underfunded. Healthcare costs were extremely high, and in terms of cultural factors, doctors and lawyers traditionally operate in different professional silos, which made collaboration challenging. There's a lot of distrust in the legal system, particularly from immigrant and marginalized communities and low-income families. And then social factors include health disparities, housing and education security, such as unsafe living conditions, as mentioned before, and then lack of awareness, meaning many family members do not know what legal rights they have or how to access support programs like food stamps, public housing, or disability benefits. But even if families did know how, the United States of America makes it very hard and challenging to apply for these programs and to even get approved. So, considering these factors, the MLPC was designed as a proactive, integrated approach to ensure that legal services are embedded within healthcare settings and makes access to legal aid as seamless and approachable as a doctor's visit. So, the strengths is that the placement of lawyers in a healthcare settings ensure families receive legal assistance before crises occur. So, the root causes. The root causes of this are housing instability and unsafe living conditions, meaning families live in overcrowded, poorly maintained, or unstable housing, which leads to health risks like asthma, lead exposure, and stress-related illnesses. There's also a lot of food insecurity and malnutrition. A lot of children suffer from hunger and poor nutrition, which stunts development, weakens immunity, and significantly affects school performance. There's a lot of barriers to education for chronically ill children, like children with chronic illnesses like asthma, sickle cell anemia fall behind in school because they miss classes and lack educational support because rigid school policies only provide tutoring if the children misses 10 consecutive days, which does not obviously help students with ongoing intermittent health issues. There's also limited access to legal services for low-income families, like families experience legal crises, evictions, benefit denials, workplace discrimination, and they don't have access to legal help, which worsens financial and health struggles. And this simply comes from the fact that the legal aid is underfunded. The legal aid system is overwhelmed with only one lawyer available for every 6,415 low-income individuals. And not only that, but the healthcare system focuses on immediate treatment, not prevention. Like pediatricians treat illnesses but cannot address the social determinants of health, leading to repeated hospital visits for preventable conditions. And this comes from fragmented approach to healthcare, and physicians lack training in legal advocacy, and there's a lot of financial incentives that favor treatment over prevention. So, my solutions would be a community-based legal clinic and mobile health legal units. So, how this would work would be that mobile health legal units would travel to underserved communities, providing free legal consultations for housing, food assistance, and public benefits, and Trained paralegals and social workers would be available to assist families in filling out applications for benefits, appealing denials, and advocating for legal rights. My solution number two would be the expansion of preventative public policy and legal reforms. This would strengthen tenant protection laws, streamline access to food assistance, require schools to provide flexible educational support, and increase funding for public legal aid programs. Um, but my recommendation would be expand proactive legal assistance through community-based partnerships. So this would be implemented by creating satellite legal aid offices in schools, housing authorities, and community centers, establishing mobile legal teams that provide free consultations, and training social workers, teachers, and healthcare providers to identify issues early. And my recommended number two solution would be advocate for systemic policy changes to reduce bureaucratic barriers. So I would implement this by simplifying application processes for food stamps, Medicaid, and housing assistance by reducing paperwork and automatic eligibility for qualifying families. Strengthen legal protections for low-income renters. And then also, I would require schools to provide educational support like tutors and flexible learning plans for children with chronic illnesses. This would lead to fewer families that would need legal intervention, and it would improve overall child health. And while both alternative solutions have merit, I think a combined approach would be most effective. So, like a community-based legal clinic and mobile units can serve immediate needs, like I said before, and then public policy and legal reforms can create lasting change. So, the timeline of how I'd implement this is step one would be planning and creating a stakeholder engagement. So, this would secure fundings through grants, local government support, and private law firms. I would develop collaboration agreements with hospitals and pediatricians. And then step two would be to develop legal clinic and mobile unit infrastructure. So it establish physical locations for legal clinics and schools, shelters, and community healthcare systems. I would develop training programs for community volunteers, social workers, and healthcare providers. And obviously, I would design and equip mobile legal aid units with like the necessary technology, which would be used to help families apply for benefits on site. And step three would be to collect data from, or would be to evaluate program and then expand the services. So I would do this by collecting data from clinics and mobile units. I would gather feedback. I would adjust service delivery. I would adjust funding, and I would seek additional funding as well to expand the number of mobile units and community clinics. So, one similar program is one in Australia, and that's the Health Justice Partnership Program. Um, so this program has lawyers that are embedded inside healthcare settings and allows for real-time legal screenings and immediate referrals. Low income and marginalized communities is what it focuses on, and people experiencing family violence as well as like abuse. So the differences between this program and MLCP is that HJP operates at a national level with government-supported funding, whereas MLPC relies more on private foundation grants and pro bono partnerships, and that's because healthcare in Australia is free. Um, but to get into similarities, there's an integration of legal and healthcare systems between both programs. They both focus on vulnerable populations and similar populations as well. And there's early legal prevention to prevent health issues within both. Um, However, I will say there's also challenges facing HDP, like sustained funding. Despite government support, there's long-term funding that remains a concern, as well as scaling challenges, like some regions lack legal professionals for full-time embedded partnerships. So often there's a disparity of how effective this program is, and there's questions around how integrated it actually is in Australia.